Well, I certainly wouldn't implement this approach or say that this is a validated predictive biomarker. Of course not. But that's our next task. So I think we have a very robust signal, a very interesting signal, and we need to take this a step further. I think we need to now confirm these findings in a larger independent cohort. We went from a signature developed in 202 patients. We confirmed it very nicely, I think, in a cohort of 27. But we need to confirm the signature in a much bigger cohort, ideally a multi-institutional cohort. The next step to my mind would be to validate this prospectively. You draw blood from the patient before they even get any treatment. You run the assay, not knowing who does what, and then you see how this links up to their clinical outcomes. That, of course, is what you would need to do to prospectively validate the signature. What are the challenges? At this time, it's done on LCMS. I think the question is, and certainly it's not a clinical question, but it's a question that comes to mind. How rapidly scalable will this be? These are bridges we will need to cross. The fundamental question to me, once you have validated this assay, if we should be so fortunate, where would I use it? Well, I'd use it in two places. First of all, in clinic, when I see a patient and I'm deciding what to do. If I have a validated predictive biomarker telling me patient X is not going to benefit from IO, from immunotherapy, that would drive me to do something different up front. Perhaps this is a patient who should get targeted therapy. Perhaps this is a patient who should get a cell therapy modality. Perhaps this is a patient who should go on clinical trial. If I know this is not a patient who's going to benefit from IO, why am I exposing them to potential toxicity, never mind the healthcare costs and the financial toxicity, et cetera? The other place where I think it's a really compelling question is, if we have a predictive biomarker, can we then refine it to decide how to tailor therapy? Who needs Ipi/Nivo? Whose disease doesn't warrant the toxicity of Ipi/Nivo? And who can I get away with treating with Rela/Nivo or monotherapy? That, to me, is the overarching question ultimately.